Thank you, Susan. Good afternoon. You are in the home stretch. Only about 30 more minutes to go, and I promise I won't take a long time. But I knew that I was in the right room this morning when Helen said, think big, innovation. I thought, this is it. And especially working with Susan, it's like we've got lots of big ideals and we've got lots of good energy to make this happen. So what I'm going to do today, I think it's going to be more of a call to action than anything, but I do want to touch and highlight on some key points that Susan raised. And again, thank you to Kaiser for the invitation to ATA and myself. We're very pleased to be here. And I want to thank all of the other presenters because I think that today was very insightful, very honest, and very informative, and we need more of that. So let me jump in and just share with you a little bit of information about the American Telemedicine Association. We have about 10,000 members, and we represent over 450 organizations. And why is that important? Because not only are our members the large integrated healthcare systems that provide telemedicine, but they're also the vendors and the technology companies and innovators. It's government agencies. It is payers, where they all converge together. And I think that we may be the only organization where all of those entities come together solely focused on telemedicine. So earlier this year, working with the board of directors, we relaunched our strategic plan. And we said, look, we've got to get serious about this. We've been in this game for over 25 years, and we've helped shepherd it, but we need to get a little bit more aggressive. And I think that we hit on that. Telemedicine has been around, but now is the time. You know, it may not have been the time before, but I think now it is. And so how are we going to work effectively with our members, which represent these large organizations, and the telecommunication companies and technology companies, to actually shepherd in telemedicine in a way that it doesn't add additional cost to a system that's already taxed and overburdened. So more to come on that. We'll talk a little bit about that later when I share some other thoughts and ideals. But earlier today, we were talking a lot about evidence-based and what can we do. So in June, shortly after we launched our strategic plan and we shared that with all of our members, we launched a project entitled the Value Proposition Initiative. And we worked with Jason and his team and others, utilizing the NQF framework to begin to talk with these large groups about collecting use cases. So use cases that are focusing and capturing data that may not be in the public domain, so that we can begin to collect evidence and tell the stories about what's going on. And we're taking that information, we're collecting it, we're putting it in a central repository, we're creating issue briefs with it so that our members and others can actually share that information with policymakers, payers, and the like. And so when you look at the span of our members, and we say, okay, well, we want to know what's going on in emergency medicine, and you have an Avera, or you have a Mercy, or you have a Franciscan, and the list goes on, and you say, okay, give us your use cases using telemedicine, and you can pull up 10 different evidence-based studies in emergency medicine. They may be slightly different, but they may also be very, very powerful if you're going to have a discussion on that particular area, or to be able to pull up use cases based on a particular state when you're going to have a discussion with the legislature. This is what's going on with your states. Here's the use cases. Or when you want to have a discussion with a payer. So that is a big initiative of ours. And if there are those of you that would like to participate in that initiative, we will definitely welcome you into the fold. Again, we touched a lot on policy. We have a strong advocacy area. We'll continue to promote that. We have launched a policy work group that we're going to invite others in, because I think that there is strength in numbers. And while we all have our own GR departments and our own lobbyists, we're really tackling this very one-off. And I think there's some opportunities for us to have some more focused messaging. We had an intelligence briefing in the fall, and that's one of the things that Politico came back to us and said, look, when you go and you're on the Hill and you're having these discussions, we refer to digital health, e-health, mobile health, telehealth. That's very confusing to policymakers that may not live in our world where we understand what all of this means. So I think working together to have some common messaging is going to be extremely important. Again, that's a work group that we've initiated, and we'll be working with NEHI in that regard. We also talked a lot today about education and training. Again, that's another area we have created a educational work group looking at trying to create a educational framework or training framework for the industry. And I use that term education and training very loosely because it may look very different. And we talked a lot today about the diversity of the various provider groups. We get that. But there has to be some way that we can build in some standardization that will help enable many of these organizations along. And again, we hear from our members on a regular basis, even though they may have an innovation lab or an accelerator program, they call us and they say, okay, so where do I start? How do I incorporate telehealth into my overarching strategy? You know, I'm hearing it. I know I need to do it. I may have a program here in telestroke. I may have an ED. I have 166 hospitals. But how do I scale up? How do I do this in a way where it's not going to be taxing, that it's going to work, et cetera? So I think that there are some opportunities for us to really delve into this as a telehealth community and really understand what is the training and how might we look at this very differently than we have in the past. Let's use some different models for training, especially when we're looking at the medical team and or the entire team as it relates to the implementation and use of telemedicine. So again, I think that's an area where we've got a work group going, and we would like to invite others to participate in that. Again, it's another area where Susan and I were talking, and I think we're on the same wavelength. We have to do something, and it might look very different, and we should allow ourselves or give ourselves the leeway to explore and maybe do something very different. Quality. For many of you may not know, we went into a joint venture with the Clearhouse Quality Indicator Institute to accredit telehealth programs. Again, JCO does a lot of accreditation in the hospital system, but we have a lot of providers that are not in the hospital system that are also looking for accreditation, and we feel that this is a really good way to ensure a certain level of quality. So that's what we're doing on the quality front. And I guess, again, I would leave this as a call to action. There is a lot of work to be done. I think that it is doable. But I think that we have to find very practical ways to unify our voice and to work together. We can't boil the entire ocean, but I think that if we can start to identify some low-hanging fruit areas, I think we should focus in on that, and that's going to drive the bigger initiatives. And I'll leave it at that.